statistic emphasizes the importance of trauma management in the world right now.
Yes, your statement is justified. Now, we extend a warm and hearty greetings to our Honorable Dr. V. Thamuran to grace this event.
Thank you.
Dr. P. Thamuran has over 13 years of specialization and expertise knowledge in the field of anesthesiology and strong analytical thinking. He has a work experience of about 10 years in emergency medicine. Currently, he is an associate professor in emergency medicine, specialized in BLS, ACLS, PALS instructor and APLS provider. With due respect, now I invite our speaker onto the stage to empower our delegates with your knowledge of safety measures. Over to you, sir.
Thank you so much. Good afternoon, everyone. Am I audible? Am I audible? Thank you. I am Dr. Thamuran, consultant, associate professor, emergency medicine, Sri Ramachandra Medical College. Am I clear? Why did I introduce myself? Is it anything important to this topic? Yes. Really, it is very important. Since you all want to become a doctor, you are supposed to introduce yourself to the patients first. Just like that, nobody can touch the patient. When I see a patient, he or she must be very confident on you. So that's what I emphasize first, that I am so and so. I am from so and so department and from so and so medical college. So when you touch or when you see the patient, first introduce yourself. Never touch a patient before introducing yourself. Okay? That gives more confidence on them. On you, sorry. Thank you. Okay, let us go to the topic. What is trauma? Is it anything very important in our life? Can we have an interactive section? Rather, I myself talking. Is it okay? Okay? Okay, fine. Let me come down. So I'm not going to trouble anybody, don't worry. It's just going to be an interactive session, that's all. Okay. What is basically a trauma? What is trauma? Okay, it can be any traumatic injuries. Any type of injuries. Not like that, it's not an accident. Any kind of traumatic injuries happen to your body. Okay. These are the topics what we are going to see actually. See, the management of trauma patient, one of the mainstay of emergency department. Okay. How are you going to manage? Can I alone manage the trauma patient? Why? Can I alone manage the trauma patient? Definitely not. It's not that it's we. Definitely it's a teamwork. I cannot alone manage the trauma patient. It's a teamwork, definitely a teamwork. Okay, probably a 5-member or 6-member or 7-member, even 3 members. So it's definitely a teamwork. It's not that a single man can run the trauma scenario or trauma situation. Have you understood? Is it clear? You can stop me anywhere, wherever you want. Okay. For almost 90% of who survive the initial trauma, the burden of ongoing morbidity from traumatic brain injury, a loss of limb or ongoing pain is even more significant. Injury and major vascular injuries. What are the head injuries you can anticipate? Very good. Okay, fracture of skull. Okay, anything else? Okay, hemorrhage is very good. Other than that, anything? That is different. You are talking about the mode of injuries. Any other deadly injuries? Can you just any injuries? Cervical injury. Can we anticipate a cervical injury, which causes what? Cervical injury which causes what? that causes your paralysis and neurogenic shock. Okay, that causes your paralysis and neurogenic shock. Okay. Next is your chest injury. What is there in chest injury? Is it anything deadly related in chest injuries? Very good. Pneumothorax? Anything? Pneumothorax is what? Okay. What is hemothorax? Yes, blood. That's why they say it is more dangerous. As soon as you do the procedure, the patient survival rate will be higher. Okay. Next is your major any vascular injuries. What are the major vascular injuries? Any trauma which causes vascular injuries, probably fractures which causes cut down of your veins or arteries or whatever it is. So these are the main three factors which causes death in the patient. Okay, let us see one by one. Okay, a systemic approach is required to reduce the morbidity and mortality that occur after traumatic injury. See, always in trauma we follow ATLS. What is ATLS? Advanced Traumatic Life Good Support. So what ATLS follows is A, B, C, D and E. We follow this way. A, B, C, D and E. What is A? Always remember A is airway, B is your breathing, C is your circulation and D is your disability. Very good. And E is your environment or exposure. Okay, this is how we follow the protocol in trauma patients. Is it okay? Can I go next slide? Before triaging, pre-hospital care. When you see a trauma patient, what do? This pre-hospital is the patient did not enter the hospital. He is still at the injury site. How do you call the anything? Your UMS is arrived, your ambulance is there, you want to inform the nearby hospital. How do you want to do it? Yes, this is the way you are supposed to inform the nearby hospital, which is might be a tertiary care center where everybody is available. Probably your neurosurgeon, your orthopedician, your anesthetist, or whoever it is. So this is how you are supposed to inform the concerned doctor, okay, or concerned paramedics who is available nearby. So number of the casualties, probably a single casualty or multiple casualties, and age and gender. Probably you may not be knowing the age, approximate age and gender you might be knowing definitely. And mechanism of injury and injuries, probably long bone injuries, head injuries, bleeding side, and how's the patient. So definitely you must include in it. Injuries sustained, how the injuries is sustained. As it is ABC, is the patient conscious oriented, he is breathing well, his circulation is very good. That will come later stage, I will explain. Then unconscious level. How do you assess the conscious level? Very good, GCS. And what treatment has been given by you or paramedics who come to receive or take the patient to the nearby hospital. And estimated time of arrival, probably the nearby hospital, 30 or 40 or whatever it is. Okay? Is the slide is clear? Can you go to the next slide? Thank you. Here comes. Once the patient is arrived, what we do in the hospital is triaging. Why triaging is very important? Can anybody? Yes. We categorize the triaging like red, green, yellow and blue and black. What is black? I read. Yeah, black is diseased one. And red is yes, severely injured, and whatever that treatment is given, his life might be saved or may not be saved. What is the yellow one? Yes, he has got injuries. His life may be saved as soon as you give the treatment. Green is always in safer side. Probably quite aggressions or whatever it is, lacerations with minimal injuries, right? This is how we categorize the patient. And blue is intensive care unit. You stabilize the patient, either you shift the patient to the theatre or shift the patient to the ICU care unit. So this is how we categorize the patient. Okay? Have you understood? This is triaging. Okay? This is how we triage and shift the patient accordingly. Next is, what is primary survey and resuscitation? What is primary survey? Yes, primary survey is your A, B, C, D, E. Yes, A, B, C, D and E. And resuscitation, how much fluids you give. Either you give fluids, blood or blood products. That's called resuscitation. Next is your secondary survey. Secondary survey where you do all scans. Then we take up the patient to the theatre or wherever it is. The slides will come later. Okay. Next is stabilization and transfer the patient to the particular area where you want to transfer the patient to the surgery site. Please transfer the patient to the operation theatre, or blue area, transfer the patient to the intensive care unit. Next is your definitive care, that is called your ICU care. Okay? This is how we triage, do the primary survey, secondary survey, stabilize the patient, transfer the patient either to the OT or to the intensive care unit. Okay? Have you understood? Can I? Okay, this is what I told you. Red, yellow, green, blue and T. He was not added. I just included it. Okay, primary survey, airway. What are the things you see in airway? What are the things you see in airway? Actually, we see any blood, any secretions, and any deformities, any injuries in and around your airway. Not only that, here we stabilize the neck. That is called Mills. What is Mills is when you don't have cervical collar, stabilize manual inline stabilization. So you stabilize the neck first. Stabilize the neck first, put the collar. Okay? Cervical collar, apply the cervical collar. This is the first thing you do when you receive a trauma patient. Stabilize the neck, put the cervical collar. By applying cervical collar, you are supposed to screen the neck. Don't forget, you are supposed to screen the neck. I will tell you later why. Then, no secretions and no airway compromise, no stridor, nothing, and patient is fine. That means you don't have to do anything. You have to apply the cervical collar. Okay. Why I need to apply the cervical collar? Yes, it's a cervical stabilization. Why I need to know? Why I need to do it? I'm just stabilizing the cervix so that I make him not to move the neck so he doesn't get injured. We may not be knowing till we screen the neck. So it is preferable to stabilize the neck, make the patient not to move his cervical region to avoid the injury. Okay? Okay. This is airway. Are you all clear with airway? Fine. Next is breathing. What I am supposed to see in breathing? What I am supposed to see in breathing? Anybody? Yes? Always chest. Always you have scanned the neck first. See whether trachea is in the midline or deviated. Next is this inspection. Completely inspect. You are just inspecting. You are just inspecting the chest now. See, look for any abrasions, lacerations or anything else. Next is your percussion. Okay, what do you do in percussion? What can you find in percussion? Yes, what is hyperresonant? Hemo or nemo? Okay. Then hemo? Dull. Yes. Hemo is dull. Okay. You should completely focus the area. Okay. Completely focus the area. Fine. Next is your auscultation. Auscultation. How do you auscultate? How do you auscultate? Please. What do you do in auscultation? Okay, you check everywhere. Everywhere you check the auscultation. What will you find in the auscultation? Very good. Vesicular breath sounds. Next. Can you hear the heart sounds? What will you see in that heart sound? I say heart sound is fine. S1, S2 is good. But somebody says, no, sir, it is muffled. That means, is there any difference? Yes. There is some sort of fluid present around the heart. That is called what? Yes, pericardial effusion. Remember that. When there is a muffled sound, you should remember there is a fluid present in and around the heart. Don't forget to look for the S1, S2. Remember that. Okay? Okay, next. You have done your inspection, percussion, your auscultation. Next is your palpation. What do you do in palpation? What is the point in doing palpation? You have done all this. What is the point in doing palpation? Fine. Confirm the inspector pending. Can you find anything else? Can you find the bony crepitus or anything like that by palpating the chest? Is it right? Yes, I can do it. By palpating, I can also find the crepitus of the ribs. Okay? Complete palpation is required. Okay? So now breathing is over. Is it okay? Are you all clear about breathing? Okay. Circulation. What is circulation? How do you see circulation? How do you see circulation? Very good. Pulse. Do you have anything else to see the circulation? Skin color. Can we see the skin color? Is it pale, blue, or pink, or whatever it is? Can you see the skin color? Okay. Then capillary refilling time. What is normal capillary refilling time? Less than 2 seconds. Remember that. Less than 2 seconds. Then next is your pulse. Where do you all see the pulse? You all start with the carotids, right? Start with the carotids. Then radial. Next. No. Dorsal spinalis is last. Is there anything in between? Yes, femoral. Radial, femoral. Ombilical is very difficult, man. You cannot find. It's very difficult. It's posteriorly present. And your dorsal spinalis. Okay? And look for the rate, rhythm, and quality of the pulse. Remember that. Okay? Okay. This is what the circulation is. What is disability? What is disability? Loss of? It's not a loss of limbs. Disability is what you have seen. What you are seeing. Is there any trauma which has caused the injury? How I am going to stabilize it? Any open wound injury, any bony exposure, any vascular injury. So give direct compression and try to apply tourniquet if your blood is not stopping. So disability wise, you have to screen everything and log roll the patient and scan for the back. Okay. Next is your exposure. What is exposure and environmental cause? Completely exposed and look for the other cause, hypothermia, acidosis, rest of the things comes in the exposure. First few things is your airway, breathing, circulation. When you stabilize these three, definitely you can save the patient. Okay? Can we go to the next slide? Okay. This is how you stabilize. So this is for intubation purpose. Okay? What will you do when you want to intubate a traumatic patient? You want to intubate the patient in a traumatic, any trauma patient. Will you extend the neck? Will you tilt the neck? No. Why? Because you don't know whether there is a cervical injury or not. Never tilt the neck. Just lift the chin alone. Lift the chin alone or give jaw thrust. That is more than enough. Okay? And see, is there any secretions? Please suction out everything. Definitive airway management is necessary if airway is not patent. Any secretion, any stridor or any sort of obstructions, please secure definitive airway with any kind of equipments which we are with you at that time. So this is how we stabilize the leg. See, that is called manual in-wing stabilization. Stabilize the patient, shift the patient in a trauma board. That is called spine board. So that because until we scan, we don't know what type of injury is present in the patient's body. Okay. Like it, please shift the patient trauma board with manual in-wing stabilization. Remember that. This is called the cervical collar. Your breathing ventilation as we discussed. So ventilate with 100% oxygen, whatever it is. Auscultate for blood sounds. Inspect thorax and neck for deviated trachea, open chest wound, abdominal chest wall motion, and crepitus of neck or chest. Consider immediate needle thoracostomy for suspected tension pneumothorax. Always done at the second intercostal space. Your needle thoracostomy. Okay, that is for tension pneumothorax, where the patient chest is not mobile equally. Consider tube thoracostomy for suspected pneumothorax. Okay, these are the deadly zones we need to know. Immediate life threatening is your airway obstruction. So once your airway is obstructed, patient cannot breathe and obviously the oxygen cannot be given and the oxygen will not reach the exchange of gas will not occur. So definitely protect the airway. And tension pneumothorax to needle thoracostomy at the second intercostal space. And your cardiac tamponade always to a needle cardiocensus. Next is your open pneumothorax and massive pneumothorax, and they are just all you need is chest tube insertion. Remember that. This is immediate life threatening condition. And next is your potential life threatening, where you can manage the patient and shift the patient to the definitive care is your tracheobronchial injury, diaphragmatic injury, aortic. These things you will come to know only after screening of the patient. Until unless stabilize the patient with A, B, C is more than enough. Okay? Can you change the slides? These are the things already discussed. Okay, circulation with hemorrhage control. As I said, look for the skin color, capillary refilling time, radial, femoral, carotid pulse and blood pressure. Look for place 2 large wide bore cannulas. That is probably 18 gauge or 16 gauge in a cubital vein to give IV fluids, blood and blood products. Okay, and begin rapid infusion of warm crystalline solution if indicated. Now ATLS says you can give only 1 liter of crystalloids. After 1 liter of crystalloids, you are supposed to give only the blood and blood products. Okay? So 1 liter of crystalloids, after 1 liter of crystalloids, you are supposed to give blood and blood product. So apply direct pressure to site of the brisk external bleeding. I will show you next slide. Consider central venous or interosseous access if your peripheral venous is not secure. Consider pericardial centers for suspected pericardial tamponade or your effusion. Consider left lateral decubitus position. Why in pregnant lady, why you need to have a left lateral decubitus position? Is there anything indicated? That too after 21 weeks, not before 21 weeks. Because the large, because the why? That is called aorta cable compression, right? So the growing fetus will compress the aorta, the inferior vena cava. So the blood pressure will not go up how much your fluid or blood you have given. So always put the wedge or put the patient in a left lateral position. Right? After 21 weeks, this is. Okay. This is the splitting in trauma. Is any injuries in upper limb or lower limb, try to immobilize. Why? Because if I don't immobilize while moving the patient, again the damage will be caused to your arteries or veins, or again bones get displaced. So always stabilize the injured part, then mobilize the patient to avoid further damage. Okay. So crystalloids, applying tourniquet if there is active bleeding. Consider, okay, tranexamic acid is an anticoagulating agent which converts plasminogen to plasmin. So it is a drug which we give to control the bleeding. Bleeding. So this should be given within 3 hours of trauma or any injury occurred. So usually we give 1 gram in a stress. That's all. So infusion can be repeated if required. So disability, that is called anisocoria. That means unequal pupils, which means there is some sort of bleeding happening inside your brain. Without screening, you can always tell if it is anisocoria, something is happening inside your brain. Okay, perform screening, neurological, mental status examination. Always go for Glasgow Coma scale. This is your Glasgow Coma. EVM. Always look for EVM. Your eye opening. No eye opening is 1. To pain is 2. And to speech, verbal something, that is 3. And he speaks spontaneously is 4. Sorry, opens eye spontaneously is 4. Next is verbal. None, he doesn't respond anything. So 1. Incomprehensible sounds is 2. Next is your inappropriate word is 3. Patient confused is 4. And patient oriented is 5. Next is your motor response. As it is none to obeys commands. It's 1 to 6. So according to this, we categorize the GCS. Less than 3 is we called brain dead. More 15 is maximum. We call it as patient is awake, alert, and everything. And indication for definitive airway is less than 7. Okay. Can I change the slide? Okay. Exposure and environmental control, triad of death, hypothermia. This is one of the major things we forgot to see patient temperature. So hypothermia can cause the patient death. Again, coagulopathy, bleeding. Again, acidosis, bicarbonate level. So these are the triad things we definitely need to assess side by side, where we do the ABG and rest of the things here. Keep the patient warm. Look for any occult injuries and give blood products and correct the acidosis if required. Okay. So next, the primary survey ends with this urgency. What does it mean is your nasogastric tube. Will you put the nasogastric tube before the screening? Usually it is not advisable because your base of skull fracture, we may not be knowing the base of the skull fracture. Always screen your brain, then go for your nasogastric tube. Next is your blood gas and capnography, urinary catheter to monitor the urine output, and ECG. Always remember, you should take the ECG, and first is completely scan the abdomen. So you scan the liver and kidney where you find any fluid collection in between that. Then again, spleen and kidney, find the fluid in between that. Always remember to scan the bladder, okay, to see is there any bleeding present in between the bladder, or bladder is full or bladder is empty. Okay. Remember that. If possible, if you have any echo probe, then you can screen for the heart to rule out your effusion. Okay. Okay, this is your first your nexus criteria. So reassess before secondary survey. Always once to go ahead and go for a secondary survey, again reassess the patient from the beginning, like A, B, C, D and E. Remember, you should reassess the patient completely before going to the secondary survey. Okay? Never miss anything in primary. That is, primary is very important. So secondary survey is it's nothing. So you have done everything in the first part. Now you get the signs and symptoms of the patient, age of the patient, any medication, past history, last oral intake, events leading up to the incident. These things definitely you need to ask for the ask to the patient if patient is conscious oriented, or you can always ask to the attenders. Then mechanism of injury, how is injury occurred is blunt trauma, any penetrating injury or thermal injury or asthmatic injuries. Okay. So head to toe examination comes here actually. From head to toe completely to the head to toe examination. Look for your laceration, operations, then injury anywhere. So you should look from head to toe examination. Do the log roll here. While doing the log roll, definitely stabilize the neck, stabilize the pelvis, do the log roll, look for the spinal injuries or spinal cord injuries. You can always see by examining. And never, when you do a log roll, please examine rectum. Per rectum examination is very important because sometimes we miss the bleeding. So always in trauma patient, we tell them to do per rectal examination without fail because we miss the bleeding per rectum. So look for deformity, discoloration, contusions, abrasions, puncture or penetrating wounds, any burns, tenderness or lacerations. So these are the things you should look in the secondary survey. So these are the signs of your basal skull fracture, any rhinoria or autoria. So these are the signs of your basal skull fracture. So hemoperitoneum signs, your great donor sign and your Pillen sign and genitourinary tract injuries. Never miss this actually. Per rectum, genitourinary and your abdomen must be examined without fail. Can I? Okay, reassess again. Never forget reassess from again A to E, A, B, C, D, E. Then reassess the patient. You think and your team thinks that patient is conscious, patient is stable enough to shift the patient to the scan. So here comes next you shift the patient to the CT, X-rays or whatever it is, bronchoscopy, endoscopy or whatever requirements. Definitely you can. You want to perform a definitely you can. So reassess the patient completely from head to toe again. Do the A, B, C, D, E from the beginning. And if you are really satisfied, always send the patient for scans. So documentation is very important. Why? Because here document each and everything whatever you do. How much fluids has been given, what drug is being given, and what management is being done. And it is a medico-legal case. Remember that. So consent for treatment. Remember that. Get consent each and get consent. If I am going to perform IT line, get consent. If I am going to put a central line, get consent. If I am going to give blood products, get consent. Remember, you need to get consent for each and everything whatever you do on the patient. Either with the patient or with the attender who is next to you. And it is a medico-legal cases. Okay. Next is your forensic evidence. That is in deceased patient, you send the patient for your PM. Okay, postmortem. So summary, emergency patient management is always a teamwork. Remember, know your roles and responsibilities. Prioritize always A, B, C, D and E. Address life-threatening injuries first. Carry out detailed examination. Maintain clear documentation. Any questions? Any questions?
So you mentioned about hazmat injuries. So what is the
So like a chemical injuries, all you have to do is prepare yourself with personal protective equipment, nothing else. So see, whatever the injuries, they will tell you if it is chemical borne injuries or any borne injuries, any hazmat injuries, So they will tell you that these patients are coming from in this area. So you will be prepared with your personal protective equipment, your goggles, your gowns and your gloves, all those things. So, and remember, sorry, this is apart from this, but whatever it is. And when you touch the patient, remember, before touching the patient, never touch the patient in your bare hand. Always remember, think that every patient is HIV and HBsAg positive. We don't know who is HIV and who is HBsAg positive. I always tell my student to wear glove at any cost. When you touch the patient, remember, you wear glove, any procedures, sorry. When you do a procedure, probably IV line or central line or catheterization, remember to wear a glove. Without glove, never touch a patient. Thank you.
Thank you, sir, for your words of wisdom.
Our delegates will take back the strong knowledge on trauma management back home.
Thank you, sir.
I humbly invite Motisha ma'am from Academic Committee of the Synod to felicitate our guest speaker, Dr. P. Tamilanbu sir.
Please, sir.
மேம் ஸ்டார்ட் பண்ணலாமா? ஆ
Now we move on to our next session, diabetic foot care.
Around the 5th century BC, the famous Indian surgeon SUSHRUTA, in his work Samhita, identified the term Madhumeha and pointed out not only the sweet taste of the urine, but also its sticky feeling to touch and its ability to attract ants. The disease persistent in time has resulted in numerous complications.
Ajay, this sounds familiar to diabetes.
Yes, the age-old disease Madhumeha is the current world's menacing disease diabetes. And our next workshop for the day deals with the critical topic in diabetology, which is the diabetic foot care. Today, we have two guest speakers, Dr. K. Murali sir, who is a reputed physician in the field of surgery, and Mr. R. Rajajabakumar sir, clinical manager from Smith & Nephew.
We would warmly greet our guest of honor, Dr. K. Murali sir. He has done his MBBS and MS General Surgery. He has done his MBBS and MS General Surgery in Raja Muthaya Medical College and Hospital, MCH Plastic Surgery in Stanley Medical College and Hospital in 2016. Currently, Dr. Murali sir is working as an assistant professor of plastic and reconstructive surgery at Government Keel Park Medical College. His publications include Flap Delay vs. Division in Tubed Groin Flaps in the Tamil Nadu MGR Medical University Journal, Acquired Tuffet Angioma Case Report in Journal of Evolution of Medical and Dental Science 2013. He was honored by our Honorable Chief Minister of Tamil Nadu for being a part of the first hand transplantation in the state of Tamil Nadu, February 2018.
Now let's welcome our speaker, Dr. K. Murali sir, on the dais to explain about the basics of diabetic food and management and inculcate the knowledge about it to our delegates. Welcome,
Welcome,
sir.
sir.
Good afternoon, friends. We're going to talk on diabetic foot ulcer today. And if you see, the foot is an excellent piece of architecture in itself. Am I audible? Yeah, okay. The foot itself is an excellent piece of architecture in itself with 26 bones. And like, okay.
Hello.
The foot consists of
Hello. The foot consists of 26 bones, 33 joints, and hundreds of tendons, ligaments, and so on and so forth. And we will grossly discuss on the definition, etiology, risk factors, pathophysiology, presentation, clinically, and classification. What is the meaning of diabetic foot ulcer? A non-healing or poorly healing break in the skin below the ankle in an individual with diabetes, typical in the national history of diabetes.
what are the risk factors? Like they want to see that. You want to see that.
The various risk factors which leads to a diabetic foot ulcer such as neuropathy, PVD, and abnormal foot pressures. And one of the major causes for this is diabetes, that's hyperglycemic state. So basically the kind of factors which causes the diabetic foot ulcer, which is limited joint motility, that is stiffness, ischemia, and naturopathy. And the three pathogenic mechanisms involved in diabetic foot are neuropathy, angiopathy, which is ischemia, and infection. So with the gross pathophysiology, the first and foremost being diabetes mellitus, which is persistent hyperglycemia, leading to a various triad of symptoms like diabetes, neuropathy, peripheral disease, and infection, and so on and so forth, which leads to macro and microangiopathy with neuropathy and abnormal function, which is the bacterial level, the cellular level, which causes impact angiogenesis and naturopathy, leading to diabetic foot ulcer. The gross clinical presentation, we should always check with the history of the patient at first. And onset and progression of the ulcer is also, and constitutional symptoms such as fever is supposed to be good for the patient. And on physical examination, the ulcer has to be examined. And neuropathic foot is warm, well perfused, and palpable pulses are always there, except for sweating, which is diminished. Whereas in a neuroischemic foot, it will be pulseless, it will be cool, clammy, the skin is thin, shiny, and without hair. And this is a careful examination, you have to always examine the foot. And neuropathic foot with plantar ulcer is surrounded by callus. You can see the callus is the second metatarsal and the first metatarsal bone, joint. The ulcer is always examined for size, shape, depth, margins, color, order, base, and flow. And the type of discharge is going to exhibit. And the discharge is always sent for culture sensitivity, and always an attempt is made to express the pus, and the pus is also sent along with the tissue for culture sensitivity. The multitude types of ulcer, what is neuropathic ulcer or ischemic ulcer, or a combination of both a neuro and ischemic ulcer. Usually we probe the ulcer with a probe to look for sinuses and to tap on the bone and to see the joint and tendon shape. And always we have to palpate the vessels, servus earlier telling, we have to always palpate the vessels, dorsal spines, posterior tibial, popliteal, femoral, etc. We always have to measure the capillary return also, which is 2 to 3 seconds is normal. And look for color of the foot, which is cyanosis and erythema. And changes of ischemia, skin atrophy, nail atrophy, abnormal wrinkling, diminished figure can also be observed. And neurological examination is always through pressure and touch, which is with a monofilament test called SIM test, or vibration, that is with a tuning fork of 128 Hz, and pain is usually perceived with a pinprick or a neurotin. And temperature, which is for hot and cold also has to be checked. Usually monofilament test is done at 9 sites on the plantar region and 1 site at the dorsal region. If you want to further know, you can always have the study, you can check how the monofilament test is done. And the musculoskeletal deformities, the attitudinal posture of the lower extremities and foot has to be always examined. The orthopedic deformities such as hammer toes, bunions, sharper deformities, amputations, prominent metatarsal heads also has to be examined and rolled out. A limited joint mobility, which is both active and passive movement, also has to be examined at this point of time, and you also have to look for tendinoatrial earlier contractions, which can cause plantar ulcers. The evaluation of skin and nails for the foot. Skin appearance has to be examined. The skin color, texture, curve, quality also will be altered in diabetes. And there will be loss of calluses and fissures and intertrigo between the rib space, which has to be carefully examined by a person daily on day-to-day basis. And if at all there is intertrigo, one has to place a toe separator such as this, and you can separate the ulceration of the or intertrigo of the rib space. This is also called interdigital lesions. Okay. We'll always have to look for nails. There can be onychomycosis or dystrophy or atrophy also can be happening to the nail and nail plates. So it's basically fungal infection. We have to rule out that. So classification is broadly on Wagner's and University of Texas classification. This is the Wagner's classification which is used throughout widely by all diabetologists. So it's graded from 0 to 5, grade 0 being intact skin and 5 being full foot gangrene. And we usually see in our setup it's usually grade 2 and grade 3. This is a University of Texas classification system for diabetic foot wounds, which contains both staging and grading. Staging is A to D, A being no infection or ischemia and D being infection or ischemia which is present. Grading is 0 epithelialized wound and grade 3 wound penetrates to the bone and joint, which means there is involvement of the joints and bones. This is the University of Texas classification. We basically work up the patient based on the fasting random and HbA1c, which is a 3-month average of the blood glucose level. And we see his blood counts to see if there is any ongoing infection or inflammatory pathology which is going on, to see his raised blood counts and to see his ESR also if it's raised. And we always take a wound and peripheral and central culture is always taken to rule out any infective situation. Imaging, vascular investigation, neurological investigation will come hand in hand. Imaging is usually a plain radiograph. With a plain radiograph in X-ray, we can say if at all the person foremost point of osteomyelitis is always detected in the plain radiograph X-ray, where there will be periosteal thickening and periosteal elevation will be there. An MRI is good in diabetic foot, but the problem is it will always over-diagnose. So a plain X-ray will do good, and a bone scan also will be useful to differentiate between soft tissue infection or osteomyelitis and Charcot. In vascular examination, we always evaluate using Doppler to rule out the macroangiopathy in the vessels, and the ABI, which is nothing but ankle brachial indices, and toe pressure measurements, and transcutaneous oxygen tension. This transcutaneous oxygen tension is the latest modality of investigation at the vascular level. The ABI usually we measure the pressure at the ankle and the brachial level, and we see for the normal ratio, which is usually 0.9, 1.0 to 1.4 is normal, and acceptable is 0.9 to 1, which is acceptable, and less than 0.5 is severe arterial disease. And toe pressure measurement is usually done by applying it to manometer to the great toe and measuring along with the manometer to see what is the pressure in the toe. And transcutaneous oxygen tension is the latest modality in knowing the oxygen at the tissue level, and it's usually graded as critical to normal. Critical being 0, normal is greater than 45. And this is toe pressure, TCPO2. This is how it's measured. You place sensors on the dorsum and the plantar aspect of the foot and measure with the Doppler to see what is the PO2. An assessment of plantar foot pressure. High plantar foot pressure have been identified as significant risk factor for ulceration. Measurements are also to be done regularly as important changes in the distribution at level. Pressure under diabetic neuropathic feet occur during a relatively shorter period. There's something called the Harris mat, which I'll show you. This is the Harris mat where the patient has to walk or stand, and we will be able to take an imprint on a plain paper, chart paper. Now I will be able to see his arches of the foot and the pressure distribution at various points. There's something also called a pedogram or gait analysis where there are multiple cameras and sensors will be placed in the empty room. The patient is asked to walk on a computerized mat, and we will be able to measure his pressure points at various parts of the heel. Heel, toe, this is the inner sole, the instep. Okay. Wherever that denotes red, that's a huge pressure, that's maximum pressure is there, exerted by the foot. And wherever there's a blue zone is almost normal, 0. And the green zone is EPO, around 200. And the gait cycle, if at all, we see the two stances, the stance phase and the swing phase. And if at all we see the major pressure is exerted at the heel and the toe, during the toe of the heel lift space. And how do we manage? There are two types of management, one is operative and non-operative. Operative is wound debridement or surgical correction, and non-operative is wound care and reduction of plantar pressure with external supports. We carry on with the routine surgical debridement of the ulcers. And the ulcer, as I told you, Wagner classification 2, 3 or more is only intervened. Rest of the ulcers are left to heal non-operatively. So the indication is grade 3 or greater ulcers only, and especially in infected wounds. And the goal of wound care is to provide a moist environment and to provide a dressing which absorbs exudate and acts as a barrier and offloads pressure. So various types of wound care products, the transparent films like polyurethane film and adhesive layer, semi-permeable. This is a polyurethane film. This is a hydrogel. Okay. What it basically does is, this is a foam dressing, polyurethane dressing. What it basically does is, it tries to absorb all the exudate exuded by the wound and retains the moisture. These are hydrocolloids, carboxymethyl and pectin gelatin material also used. And this is calcium stop, which is nothing but calcium arsenate. Whenever there is a contact with blood, the calcium gets solidified and there is loss of blood is stopped. There's collagen dressing, this is biofilm, which is nothing but particulate collagen, which helps in wound healing. How do we reduce the plantar pressure? Offloading. This is a non-surgical offloading. The methods are total non-beam bearing, TCC and CAS, something about TCC, total contact CAS. Wherever the ulcer is present, we try to offload the area and we give a cast, POP cast. So the ulcer will be offloaded. So once the pressure is offloaded, the wound automatically heals subsequently with time. And these are foot casts which can be of boots which can be removed and reapplied again. The boot contains of multiple soles and multiple layers of soles and multiple layers of other materials which do not, which offloads the ulcer. This is a pro boot, which is also called the Charcot restraint orthotic ball boot, which can be used for Charcot patients. This is a half shoe or wedge shoe. This is basically used to offload the ulcer at the plantar region, the forefoot or the hindfoot. This is used for the forefoot and this is used for the hindfoot. This is a patellar bearing brace, which is again used to offload pressure. This is a plastic zone insole. It's a specialized material insole, memory foam material, which can be used. These are the latest insoles used in modified footwear. And the accessory design devices like walking crutch, walker or a wheelchair can be used to offload. Vascular management basically is to relieve the patient of ischemia. It can be either invasive or minimal invasive. It can be through angioplasty or can be through surgical bypass also. Surgical management to reduce or remove body prominence is usually done to remove the body spicule which will be impinging on the soft tissue and creating an ulcer. So we try to remove the bony impingement. This is how we are done here. So this is a correction of hammer toes. Patient usually, diabetic patient usually that due to intrinsic imbalances, patient develop hammer toes or claw toes. The claw correction is usually done by arthroplasty of the PEP joint. And this is before picture, this is the after picture where we introduce a KY after doing the arthroplasty. This is a hallux valgus deformity of the bunion. This is also corrected using bony excision. We excise the bone over here at this joint and introduce nailing. We nail the metatarsal and we correct the deformity. This is also due to intrinsic imbalances in diabetic foot. This tendinogenesis lengthening is done to reduce the stress. Look, the patient is having plantar flexion, so he is prone for plantar ulcers over here, forefoot ulcers. So what we try to do is we try to reduce the tension over here and we try to make the foot neutral. So the height stress is relieved and by lengthening the tendon, the tendon by multiple Z plasties or you can even go for a GSR or a Z cut. There are other techniques where you can do. This is a patient where this tension has been relieved. This is beyond the scope for today, but these are some things called internal offloading. All these procedures are called external offloading. We have seen these are external offloading. These are internal offloading. These are preventive surgeries, recular arthroplasty. Wherever there is a bony prominence, we relieve the tension over there internally, and we cut. In simple terms, we try to cut this bone and relieve of the tension, and automatically the weight ulcer heals without any intervention. This is the flexor tenotomy. We try to cut the flexor tendon, which causes tension or rigidity over here, and we make the bone lax, and automatically bone heals. This is another claw toe, and this is also beyond the scope for today's class. Wherever there is a raw area, we can always reconstruct with flaps. New tissues can be brought in, and we can always give them near normal food. In diabetic foot infection, which is non-limb threatening and limb threatening, which is non-limb threatening. I talked to this in sometime. This is one of the local signs of foot infection we always know. The granulation tissue becomes increasingly friable, and base of the ulcer becomes moist and changes with pus discharge or exudative discharge in unpleasant order. So non-limb threatening infections of the diabetic foot will initially can be managed in the OPD or OPD basis, and they can be monitored for 48 to 72 hours and to see if the condition deteriorates, and they usually respond to antibiotic therapy well. The ulcer management is followed by correctional dressings and non-surgical methods. In limb-threatening situations where the patient has a cellulitis or a necrotizing fasciitis with pus or abscess in the plantar and the dorsal aspect with the ganglion toe, we usually intervene at this point of time and we try to remove the necrosed or non-viable tissue, and we will try to relieve the pus by doing incision drainage and try to salvage the foot by removing the necrotic tissue. Antibiotic is started as an empiric regimen initially, and once we get the results of the tissue for culture which has been sent in 48 hours, we try to shift the patient from empiric therapy to a complete therapy. As an empiric therapy, we always go for broad spectrum antibiotics and given intravenously. The minor infections can be treated with narrow spectrum antibiotics also. Mild and moderate non-threatening infection are usually monomicrobial and respond with good antibiotics. Severe limb ischemic limb-threatening infections are polymicrobial and needs intravenous injections, and pseudomonas species are often isolated in blood vessels, enterococci and cephalosporins, and MRSA in previous hospitalized patients. Empiric intravenous broad spectrum antibiotic therapy in patients should cover common isolate of organism and then adjusted according to the cultural sensitivity results. The duration of antibiotic treatment for moderate infection usually 1 to 2 weeks. In serious infections, more than 2 weeks has to be continued. And for patients with osteomyelitis, it has to be up to 6 to 8 weeks. And if at all the patient is having a vascular ischemic limb that has no, wherever there is a vascular impairment, we have to revascularize the limb, or vascular reconstructive procedure has to be carried out so that this antibiotic will respond in a better fashion. And maintaining effectiveness of therapy through parameters include the patient's clinical response. You see how he responds to the drugs, and see the temperature of the food, and see his counts returning back to normal and ESR returning back to normal, and check for other inflammatory markers, and basically sugar coming back to normal. Whenever there is infection, the sugar is always spiked up and it never comes back to normal. Whenever there is mild to moderate, we always go for oral cefalexin, amoxicillin, clindamycin is the drug of choice for me, myself always. It's always 600 mg PID. And in moderate to severe, we usually go for higher antibiotics like Clinda, topped up with other Cipro or Ampro. And life-threatening, you always go for imipenem or meropenem and ampomycin. How do we prevent? Prevention is always by educating the patient. Patient education comes first and foremost. And with foot care, proper foot care, you explain the patient that he has to sit down after every bath. Daily in the morning, spend 10 to 15 minutes. Check his foot for calluses, new infection. Look for intertrigo, so on and so forth. And always wear therapeutic shoes, and always make it a point to change the shoes or your slippers within that stipulated time of 4 to 6 months. And reduction of plantar pressure by wearing therapeutic shoes or insoles and so on. It's usually multidisciplinary approach. So you need a diabetologist, endocrinologist, you need a general surgeon, physiatrist, physiotherapist, so on. So you explain the patient about, you teach the patient about diabetes management basically, and daily feet inspection, to apply moisturizer, and to soak the feet in lukewarm water and remove the calluses accordingly, carefully clip the toenails accordingly, and to always wear a proper footwear and wearing socks to bed, because many of the diabetic patients, it is due to insects and due to mouse bites, there will be ulceration. And you should always watching the patient, tell him you should never walk barefoot, because you'll always have neuropathy. So thank you. This is the first step of Neil Armstrong when he went on the moon in 1969, July 16th. Thank you.
I humbly invite Shiny Ma'am, President of SNO, to felicitate our guest speaker, Dr. Murali sir.
Thank you, sir, for being here today. We are deeply grateful for your participation.
Our next speaker for the topic is Mr. R. Raj Jivakumar sir. He is a clinical manager in Smith & Nephew and has over 10 years of extensive experience in training doctors and nurses all across India, Nepal, Bangladesh on advanced wound care, and is a certified diabetic educator.
For the last session of the day, we now request Mr. Raj Jivakumar sir onto the dais to talk about wound care and wound care products and educate our delegates. Welcome, sir.
So, good evening all. Good evening all. Good evening. So So I have got 70 more slides. So I am going to bore you again. Shall we start? Are you ready? Okay. So today I am going to talk to you on something on wound care. So how many of you want to become a surgeon here? So how many of you want to become a surgeon? So you don't have choice here, listen to me. Okay, so what is your understanding about wound? Anything? What is your understanding about wound or diabetic foot? What is your understanding? Is it something that is needed in the community? Do you think we need more surgeons for treating wounds? Do you think India needs more surgeons for treating wounds? How many of you say yes? Raise up your hands. Okay. Do you think a surgeon can earn more money in wounds? Any idea? Okay. So, do you see? I'll ask you some simple questions. See, for example, I'm going for a cardiac surgery. I'm going for a single vessel disease. Okay. So, CAPG. What will be the total cost of my treatment? 3 lakhs, 4 lakhs, 5 lakhs max, right? So, if I am having a diabetic wound, I am having a small ulcer in my foot, I am going for a treatment. What will be the cost of diabetic foot treatment altogether? Any idea? Any wild guesses? I am having a diabetic foot, I am a diabetic patient, I am having an ulcer in my foot, and the wound is not healing. I am going to a surgeon for multiple times for surgery. What will be the total cost of treatment? Any idea? 70,000. Any other guesses? 2 lakhs. Great. So you are coming closer. So it is not me. Ministry of India, Department of Health and Family Welfare says. Ministry of India, Department of Health and Family Welfare says to treat a small ulcer, okay, which is in the size of a 1 rupee coin in the plantar surface of the wound, foot, patient has to spend 5.5 years of his average annual income. I repeat, if I am having a diabetic foot ulcer, if it is in my sole of foot, I have to spend 5.5 years of my average annual income. Right? So one more question. So if I am having a breast cancer, you know, right, male also can develop breast cancer, right? If I develop a breast cancer, if it is operated, so I am responding to the therapy. So how many years I can live after breast cancer? Roughly. 10 to 12 years, right? Minimum. So if I am having a knee replacement, so I have to go again for knee replacement, right? How many years I can live with the same implant? 10, 15 years. Now latest implants are which can last for 32 years. But if I am having a diabetes, my foot is amputated. Okay, if my foot is going for amputation, do you think how many years I will live after amputation? Life expectancy of a human being after amputation. What is the age? What is the time? Published data says it is less than 5 years. Published data says it is less than 5 years, and nowadays many data are coming which says patients dies within 3 years after BK of bony amputation. We can see all those things, right? So today we are going to discuss about what is wound, how to treat wound, and as clinicians, as upcoming surgeons, I will try to understand how to basically treat all kind of wounds. So when you do dressing, what will be your objective? So you would have done dressing, right? Or you will be doing dressing. So when you do dressing, what will be your objective? To prevent exposure. Main objective is to make the wound healthy, right? So you are going to make the wound healthy so that you can put a graft or flap over it. Basically, you want the granulation to happen, right? So if you see, wound bed preparation is management of wound in order to accelerate endogenous healing or facilitate the effectiveness of therapeutic measures. So by nature, any wound has to heal by itself. But when we are dressing a wound, what we think, we make an environment so that the wound is going to heal by itself. Or if you are putting a graft or a kind of dressing, the dressing is going to work effectively. Okay, this is a small video. I just want you to play the video. Kindly tell me what you understand from this video. Play the video. go to the next thing. So what I was coming to say in the video is, see, you cannot treat, see for example I am having a wound in my hand. So one wound is present here, one wound is present here. You cannot apply same dressing for both the wounds. You cannot treat the wound in the same way what you are treating here, because it is in the joint. So patient will be moving. So you cannot have the same kind of dressing in this area. So it differs various places to places. So wound bed preparation is based on integration of time principle. So debridement, when you are doing a debridement is an ongoing process. Why do we do debridement? Basically to remove the bacteria in the wound. So always you have to understand moisture in the wound has to be controlled. So when you are treating a wound, what do you expect from the wound? You expect granulation to happen in the wound, and also the sizes of the wound you are expecting to come closer. So if you see, this is time principle. If you understand this TIME, you can understand the entire concept of wound healing. Okay. So when you open the wound, okay, see some examples, simple examples I give you. So when a woman is going for an antenatal checkup, when a woman is pregnant, okay, she is going for ultrasound abdomen. So what is when you are doing ultrasound of abdomen, what is your objective? A woman is going for a woman is pregnant, she is going for an ultrasound abdomen scan. So when a physician does the ultrasound, what will be her objective? She will see whether there is a heartbeat, if the baby is present. Sometimes there can be growth also, right? So she is first understanding whether there is a heartbeat. It means baby is alive. It is a live fetus. And then what will they find? They will see whether the fetus is implanted in the uterus. It is not in fallopian tube. It is not somewhere else, right? And then what they do? See the gestational age, all those things. And then if it is alive, what they do? Ask the patient to eat well, take rest, take some kind of iron tablets, folic acid, all those things. The same way, when you open the wound, when you are seeing the wound, you have to see whether the tissues in the wound are healthy or not. If it is healthy, what you are going to do? You are going to preserve it. If it is unhealthy, you are going to remove it. Same example, if baby is dead, mother is 8 months pregnant, there is a IUD in the abdomen, what they will do? They will take out the baby, right? If it is not taken out, what will happen? Baby will go for maceration, ultimately death might happen for the mother as well. So first thing is, you have to see whether the tissues in the wound are healthy or not. If it is healthy, we are going to preserve it. If it is not healthy, we are going to remove it. So what is time principle? See, for example, in acute wound, the acute wound always heal in a sequelae. There will be bleeding, there will be coagulation, there will be granulation, and finally the wound will be healed. So that is why in acute wound we don't see any scars. But whereas in a chronic wound, sometimes it takes much longer time to heal. So see, for example, these are the factors why patient's wound is not healthy. Why you see dead tissues in the wound. So when there is no blood supply, when there is deep infection, when patient is having low albumin, the main reason why patient develop bed sore is because of low albumin and protein, immobility, all those things. See, for example, this is a tissue. When a patient comes to you, you are opening a dressing, and if you see that there is a totally necrosed, gangrenous toe. Can you preserve this? You can't preserve this, right? If you think it is going to spread, if it is going to spread, again it is going to cause serious problems. Sometimes patient will go for sepsis as well. There is high chance we might lose the patient. The same way, if you see this is an hemorrhagic ulcer, right? In the shin of the patient. This is also not healthy. Can you just keep it for a long time? No, it is going to harm the patient. So that is why we do debridement. Why do we do debridement? To clear away the dead or necrotic tissue, and also we are ensuring that there is enough blood supply to the wound bed. See, for example, this is called as Hani. In Tamil it is called as Hani, right? How do they occur? See, your doctors, right? Your parents, grandfathers, they will also have this kind of problems. They will ask you, I am getting Hani in my food. What will be your education? What will you tell them? One step if you tell that they can prevent Hani. What is that? Avoid walking barefoot. If they wear diabetic footwear, 99.9% they can prevent this kind of problem. So if you see, this part is healthy, right? This is totally healthy, but the surrounding area is unhealthy. Until unless this rim is taken out, this wound is not going to contract. So this is debridement, removal of dead tissue to promote faster wound healing. So why we are doing this? To remove the callus and necrotic tissue, to decrease the bacterial burden, and also we are removing the unwanted cells. So there are different types of debridement. So for example, autolytic, surgical debridement, enzymatic debridement, mechanical debridement, biological therapy. There are different, surgical debridement, right? But other debridement will be something new to you. I will tell you what it is. Surgical debridement, you know. So when there is a dead tissue and you want to remove the dead tissue and you want to see the base of the wound, you are going to do a debridement, that is called a surgical debridement. See, for example, a patient is having a breast ulcer. So here the opening is very small, but you do not know what is internally happening here, so you want to make the wound little bigger. So you are using a surgical procedure to remove the dead tissue so that the base is exposed. This is called a surgical debridement. So what is autolytic debridement? So simple. How many of you are living in hostels? How many of you are hostels? Okay, great. So you all want to go, right? You want me to finish fast so that you can go to the hostel. Okay. So imagine you are making chicken curry or mutton curry today. So you are cooking chicken. So you want to wash the utensils. How will you wash them? See, boys are answering, girls are keeping quiet. So how will you wash your utensils? Imagine you are making a chicken curry. How will you wash them? You soak them in water, right? When you soak them in water, the next day what happens? Slowly you can scrub it out. The same way, autolytic debridement means. So autolytic debridement means automatic debridement. So it occurs spontaneously in all kind of wounds. See, for example, when there is a wound. So when there is a wound, after debridement, you have a little bit of dead tissues left behind. You can't remove them because they are very adherent. So in those cases, there are certain ointments called autolytic debridement ointments. They are called as hydrogels. In the market, if you see, there are ointments like Mehail, Hydroil, Intracycl, this kind of ointments. So what they contain? They contain only water in form of gel. I repeat, this kind of hydrogels, they have nothing but water in form of gel. See, if I keep water here for some time, it will get evaporated, right? So, but if I keep the gel here, it will stay there for 3 days without evaporation. Because they have made it in a solid form so that evaporation is avoided. So, this kind of gels, okay, imagine you are debriding a wound, after debridement also there is dead tissues present. So, in those kind of wounds, you can put this kind of gels. These gels are nothing, water in form of gel. So, when water is there in the wound for a very long time, what will happen? It will slowly detach the dead tissues. So, after 3 days or 4 days, when you want to wash the wound, you can clearly wash them. What is the disadvantage? If the wound is infected, you can't keep the wound closed right for 3 days. That is the only disadvantage. So how does it work? The mode of action, it gently breaks the dry necrotic tissue, it provides moist wound environment, and it is soften the necrotic tissue so that the necrotic tissue is removed easily. So enzymatic debridement. So I told you, so you are soaking in water. You have made a chicken curry, you are washing it, you are soaking in water. Even after some time it is not coming easily. What will you do? You use Pril, rinse soap or something, right? This is example of enzymatic debridement. So here there are certain enzymes. In ointments there are certain enzymes, usually peptide or urea. So this ointment, when you put into the wound, this peptide or urea will slowly remove the dead tissues. So the ointment that is available in the market are called as debridase, collagenase, all those kind of ointments. So mechanical debridement using some kind of ultrasound device or some kind of hydrosurgical debridement to remove the dead tissues. Biological therapy is, this is not very commonly practiced in India, but I do visit Malaysia for some time. So every 3 months I go once to Malaysia. In Malaysia this is very, very common. So see, when I was working in clinicals, I will tell you a small story. One patient came with a big ulcer. Okay, there was no smell. Patient came with a big ulcer. When we removed the dressing, we saw worms coming out. Hundreds of worms were coming from the wound. So my plastic surgeon, when she saw the wound, she was very happy. She said, remove all the worms, get anesthesia fitness. If patient is okay, tomorrow we will put a graft. So I was wondering, what is wrong with the madam? Patient is having worms in the leg and she is again going for a flap surgery. Madam told, when these worms are there, this worm seed will eat away only the dead tissues. They will not touch away the healthy tissues. When dead tissues are eaten away, infection also going to subside. So this is what is naturally happening in the human body. But certain companies, what they are doing is, they are culturing this kind of worms. Usually, there is a special species called Lucia sericata. They culture the worms. When the doctor writes the prescription, they come and give the worms to the surgeon, and the surgeon put the worms in the patient leg, and this worms will eat away the dead tissue. This is not widely practiced in India, but it is very, very common in Malaysia. It is going to come to India as well. See, for example, there is a wound. It is the medial aspect of the leg. Patient is having a vascular problem. Patient is not able to go for anesthesia and surgery cannot be performed. What they do? They put the worms. So the worms will eat away only the dead tissue. They will spare the healthy tissue. What is the advantage? You can put a graft or flap over it immediately. That is the advantage. Okay. So these are again the alginates. These are dressings when you debride. Sometimes when a patient is having bleeding, when you use this alginate kind of dressing, they stop bleeding and also they keep the wound moist. Okay, so this is first thing. When you are talking about diet principle or wound bed malformation, first one is tissue viable or deficient. If it is healthy, you are going to preserve it. If it is unhealthy, you are going to remove it. How you are going to remove it? By terms of debridement. What are different types of debridement? You understand? Autolytic, sharp, enzymatic, mechanical, and biological agents. By doing this, what you are going to do? You are going to restore the wound base. You are going to have a viable wound base. Right? Are you following me? Am I boring? Okay. And now, in terms of preserving the wound. Okay, how will you preserve the wound? We said if it is not healthy, we are going to remove it. If wound is healthy, how will you preserve it? See, this is very, very important for you because you are going to be the beginners, right? I'll tell you simple things. First thing is, when the wound is healthy, okay, don't apply any gauze over the wound. Always apply liquid paraffin gauzes. Okay, I'll tell you why. When the tissues are growing, they will grow very rapidly. When you keep gauze pieces, they will grow like this. They will not go like this only, they will go like this, like this, like this. That's the pinnacle. And when you are going to remove it, what will happen? You are going to cause again bleeding. This is first thing. Second thing is don't scrub the wound unnecessarily. Irrigating the wound is more than important. If it is in the joint, okay, if it is in the joint, immobilize the joint. It will heal faster. Usually if it is a diabetic foot, put a POP or a cast so that the patient is not walking on the wound. Right? And one more thing is, when you are putting POP, I tell you two scenarios. I have seen patient coming with cockroach inside the POP. I have seen when you put POP, you send the patient home. Patient will come, sir, it is so much itching. So when you open the dressing, you can see pen markings. They will use comb. They will use screwdrivers. And when they come and you open, you can see all those things. Here the problem is itching. நம்ம இப்போ சிரிக்கிறோம் பேஷண்ட் யோசிச்சு பாருங்க நைட் 1 மணிக்கு அரிக்கும் என்ன பண்ணுவாங்க அவங்க so what as physician how can you prevent this and itching எப்படி prevent பண்ண முடியும் how will you prevent this now it is question for physicians not for surgeons patient is having itching in the wound when you have a dressing POP ஏன் அது ஆகுதுன்னு பாத்தீங்கன்னா because the perineum area is dry. When it is dry, it is causing itching. So, initially we told to apply coconut oil. Coconut oil apply it will attract ants, rats, insects. Again, they will come to you. So, when you are educating the patient, educating them to the level of understanding important. Nowadays, what we say, don't apply any vegetably prepared oil. Olive oil, coconut oil. Don't apply any kind of vegetably prepared oil. But what oil can apply? You can apply only liquid paraffin or French oil or some kind of moisturizer can be avoided. Two things. One is don't use gauze pieces, use liquid paraffin gauzes, foams so that the tissues are not going inside. Don't scrub the wound. Third thing is when you are applying, when it is on the joints, immobilize the joint. And second thing is when you are applying grip bandage or something, always apply moisturizer around the wound so that the patient is comfortable. Right? So this will help you to improve your practice also. One doctor who is putting a POP without pain and one doctor is putting POP with pain. Whom the patient will choose? Right? Okay. This is the second thing. And third thing is never use betadine unnecessarily. When you are cleaning the wound, this is very, very important in advanced practice. Never use betadine. See, betadine is always good. But when it is used on a granulating wound, it is sometimes toxic. So what can you use? Saline is more than enough. Okay, this is about D. Second one is infection. Okay, so So when the wound is not healthy, you have to look whether the wound is having infection. So or inflammation. You know not right what is infection? When bacteria goes, when they multiply and when they form love making and when they reproduce and they produce more amount of illness, it is called as infections. So these are the reasons why patient develop infection. They will have vascular disease, edema, malnutrition, diabetes mellitus, alcoholism, corticosteroids use and other things. Local factors, see you go to India, you go to UK, everywhere, 45% of the, more than 45% of the ones they don't survive. Because larger the area, larger the chance of infection. Increased wound depth, if the wound is very chronic, when there is a foreign body in the wound. So all these reasons the patient develop infection. So these are the signs and symptoms, you know, pain, the wound size will increase, new areas wound will start forming, malodor. Okay, when a wound has got a malodor, it is the first sign that wound is getting infected. So when you put a probe, when it is going very deep into the wound, it is a sign of infection. When you have sloughs, when you have increased discharge, when the granulation not even, it is called as this thing. Biofilms, this is also a new concept. How many of you have come across biofilms? So you know biofilms, right? When the wound is very chronic, sometimes biofilm form on the wound. How to remove biofilm? Is there any drug that can prevent biofilm? How will biofilm look like? It will be very film kind of stuff. It will be very shiny, very filmy. So when wound is very chronic, it will glitter. Without bleeding, you have to take the biofilm. So why does biofilm forms? Because for cooperative, it is not only one bacteria. Many bacteria together they form biofilm. It is for cooperative nutrition and other stuff. So here, when a patient is having infection, you have to see whether it is because of high bacterial count. You have to see whether the inflammation is more, or whether the protease activity is there, whether the growth factors are good or not. If you are going to remove this, you have to remove the foci. You have to give antimicrobials, anti-inflammatories, and protease inhibitors. By doing this, you are going to reduce the bacterial count. You are going to reduce the inflammatory markers, and also the protease activity is decreased. By doing this, bacterial balance is going to be balanced. So here, as clinicians, what you have to understand is, whenever you are having diabetic food, rather than doing a swab, it is always advised nowadays to do a biopsy, throat biopsy, and send it to the lab. And one more thing is, whenever you are taking a biopsy, the time of shifting matters. You will take biopsy, you will give it to the nurse will keep it there, and she will send after 3-4 hours. You will get a false positive result. Transporting the patient to the infective, the lab is very important. As I said, diabetic food cost is 5 years of average annual income, right? Why it is costly? I said, cardiac surgery is only 1 year, 2 year income. If it is a diabetic food, I said it is 5 years of his average annual income, right? Why it is costly? Because cardiac is mostly one-time procedure. Diabetic food, when it is infected, it needs at least 3 sittings. Once debridement, maintenance debridement, then a graft or flap. And most of the time, they fail. And also when you do culture, they will be polymicrobial. It will not respond to any available antibiotics. You have to go for the IL-2 antibiotics, meropenem, imipenem. Okay? And what is the dose of antibiotics? Imipenem, what is the common dose you will write? At least for 5 days, right? So what is the cost of one imipenem? 5,000 rupees minimum. 3 dose, 15,000 rupees, 5 days. Imagine, simple. One antibiotic is going to cost. Again, anesthesia and all those things. So, treating infection, giving proper antibiotics is very important. Moisture balance. So, during COVID, I had the habit of growing plants. Initial days, I bought 10-20 plants. So, I was very curious. I started watering them lavishly. Almost all plants died. Okay. So they say over-watering kills the plant, then under-watering. Okay, the same way in the wound should not be too watery, at the same time it should not be dry also. I'll tell you why. So during the year 1962, before 1962, usually they thought wound should be kept dry. So usually before that, the wounds were like mostly war wounds or fall injuries, so the wound will be of different nature, they were not ulcers. They usually keep the wound dry. They ask you to expose the wound to the sun. They want to keep it dry. So this person called George Winter, he demonstrated various models. He said that wound heals faster when it is kept in the moist environment. So nowadays, most of the modern techniques are followed on moist wound concept. So see, for example, when you keep the wound moist, it is going to help in faster utilization. It is going to promote new blood vessels formation. It is also going to reduce the pain because the fluid is isotonic solution. It is going to reduce the thing. So, for example, the wound is very dry. It is going to cause desiccation. What is this? Eschar, right? Eschar. Okay. So, if it is dry, if you put any dressing, will the dressing penetrate this? So, imagine this is in the heel part of the patient. It has got a scar. If you are going to apply any kind of dressing, will this dressing penetrate? No, right? Because it is dry, it is already dead, it cannot allow any material to go inside. So, debridement is very, very important. So, desiccation, this is called as desiccation. It is going to slow cell migration. It will be very uncomfortable for the patient, and the treatment time is also very, very longer. So, on the opposite, if the wound is very moist, okay, it is going to the maceration is going to happen. This is also not good. Patient dressing will soak within 1 day. Okay, so always the wound should be like this. The wound should be moist, but the peri-wound should be dry. There are various dressings that are available which can do this. Okay, these are the factors why patient will have more fluids. When the patient is having extensive deep burns, when a patient is having wound infection, when a patient is having venous hypertension or cardiac failures. And sometimes when they use autolytic debridement agents also, they will have more fluid produced. So always use dressings that is going to absorb, retain and transfuse. Nowadays, instead of gauze pieces, nowadays latest dressings are available. Okay. See, I have a small kid. So when I apply diaper in the night, he sleeps nicely. But when I don't apply diaper, he cries in the night because when he go for a bedwetting, he will cry. So what does diaper do? When a patient absorbs and keep it away from the private parts. The same way, many dressings are available. When you keep it on the wound, they absorb the fluid and keep the fluid away from the wound. At the same time, they are going to keep the wound moist. So those dressings you can use. So if wound is very dry, it is going to cause desiccation. If it is desiccated, you are going to apply moisture balancing dressings. If there is excessive fluid, you have to go for compression. You can apply. How many of you see back dressings? Vacuum dressings. So vacuum dressings, you can go and see what it is. You can apply those kind of back dressings. And by doing this, you are going to reduce edema. You are going to reduce excessive fluid and moisture balance is balanced. And finally is epidermal margins. So see, for example, if the margins is like this, okay. Sometimes in this area, if you are not cleaning, this is a nidus for bacterial growth. Okay, this is called as undermining. So if this is like this, the wound is not going to heal faster. Sometimes it is punched out. So if the wound is like this, there is no healthy tissue, it is also not going to heal. If the wound is slow, it is also okay, it is good, okay, somewhere. But if it is averted or something, it is difficult to heal. So whenever you are treating the wound, you have to see the edges of the wound. So sometimes if the wound is like this, you are packing the wound. After 2 weeks, if the wound is coming closer, means wound is healing. Even after 2 weeks, if the wound is not coming closer, whereas if it is becoming big, it means wound is not healing. Okay. So these are the reasons why your wound fails. If the wound is having necrotic tissue, if there is no blood supply to the wound bed, if the infection is there, if the inflammation is not controlled, if the moisture balance is not corrected. And also it depends upon the dressing what you are going to apply. So if wound is not healthy, you are going to do debridement, skin graft, biological agents and adjuvant therapies. You know what is debridement, right? What is skin graft? You have heard of skin graft, right? So when the wound is very, very big, you can do a skin and graft. Biological agents. Can you donate your skin? Right? Skin banks are available. Those kind of biological skin also you can apply. By doing this, you are going to have a migrating keratinocytes that your wound is going to heal. So any questions on this? Time principle? TIME? Can you play this video? Just see. It's not supporting. Okay, no problem. So any questions? You can close the wound like this also if your patient allows, but it is totally non-compliant. Okay. So any questions on wound? See, I travel all across India. Okay. Okay, I see patients from corporate, I see patients from government hospital. I worked in Jammu, I'm going to Malaysia, I'm going to Manipur also. So I see wounds, people with wounds in across geographies. So my passion is for wounds. So if you have any questions, if you want to discuss with me, you can discuss later also. If you have any questions now, I can answer your questions. Shall I ask you some questions? So, how will you prevent pressure ulcer? If one of your relatives or family members is bedridden. So, if you do this one thing, you can prevent pressure ulcer. What will you do? If you have proper protein albumin along with hemoglobin, 100% we can prevent. Right? These are some tricks. Okay. Thank you. Thanks for patiently listening. If you have any question, I am here to take it. No question. Thank you. Thanks for patiently listening.
Thank you for sharing your time with the delegates and sharing your knowledge, sir.
So from this session, diabetes is not the end of joy. Cure it and enjoy like a small boy. Thank you. Thank you, sir. And now I humbly invite Dr. Tejmuli ma'am on dais to felicitate our guest speaker, Mr. R. Raja Jabakumar, sir.
Thank you, ma'am. Now we are about to conclude this event. Ends are not bad things. They just mean that something else is about to begin. And many they don't really end. They just begin in a new way.
So eventually, we are nearing the epilogue of this day. Today we had a glorious opportunity to mix and mingle with all brilliant minds from different colleges. This magnificent event made us wonder how fascinating our medical professions are. So a special thanks to all our wonderful speakers for their time and for sharing their experience with us. All these programs somewhere play a centerfold role in our lives.
I sincerely appreciate everyone's presence who are a part of this sublime Sunday. And it's an immense pleasure for us to be here with you all. Thank you, medicos. And an announcement, when your name is being called, come to the front of the stage to collect the certificates. And if you want to get suturing pads, it's about 200 rupees. Madan sir will be standing on the right side. You can pay about 200 to him and get the suturing pads. And for any future ordering for suturing pads, you can get his number from the WhatsApp.
Study hard until you can say, I'm a doctor, everything is gonna be alright. I'm not a trainer, I'm one of the sponsors on Prep Ladder. I guess everybody will be knowing about Prep Ladder. It is an EdTech platform, and we are giving 25% flat discount for the participants of SNO, this SUSHRUTA. I'm near the certificate table. You can come contact me if you have any doubts. You can clarify there and you can claim your 25% flat discount. Thank you.
Rama Prashantini, Harish Kumaran.
Because after getting the certificate, some நிறைய பேர் வந்து பார்ட்ஸ் கேட்டிருந்தீங்க கிடைக்குமான்னு சொல்லிட்டு ஸோ பேட் சர்வீஸ் போல்டு வேணும்னா அங்கே போய் வாங்கிக்கோங்க.
Preeti Tyagya, Harini, Nitishri P, Rohit P, Yugesh Khanna GP, Shantini Mutturaman, Vashni S, Kasturi S, Reshma S, Ritika S,